Well, welcome to Leading Rural Healthcare, everyone. Our conversations so far have been with leaders of rural health centers and critical access hospitals, and today we get a unique opportunity to widen that lens. And joining us is Ric Ransom, who's the Chief Executive Officer of MU Healthcare, which of course is the University of Missouri's academic health system here in Columbia. Ric is the son of a physician who I think he'll probably share with us, who early on decided the clinical path candidly wasn't for him, and so he's an attorney by training, and now he's found a way to serve patients from the leadership side. And so for nearly 2 decades, he's helped run health systems around the country, from South Carolina to Wisconsin, before, of course, coming back here to Missouri in 2023. These days, he's focused on work most leaders who listen to this program will recognize. I mean, listening to communities, bringing care closer to where people live and work, exploring new models of care and partnerships, all the while navigating the financial pressure that every system feels, regardless of size. So the difference, of course, here is just scale. So whether you run a critical access hospital or a statewide system, there are many systematic pressures that are familiar, right? And often the answers are too. So that common ground is where we're really headed today with this conversation with you, Ric. So with that, welcome to Leading Rural Healthcare. I'm so glad to have you on board.
Thank you so much for the opportunity, Brendan. I'm really pleased to be able to spend some time with you today.
Yeah, so tell us, Ric, about your journey into healthcare. Obviously, you had some family ties into the healthcare industry before deciding to get into the field yourself. I'd love to know if having a physician in the family helped shape how you feel about patient care and how you approach the patient experience, even as a non-clinician.
Yeah, thank you for the question, Brendan. And as you mentioned, my dad is a retired physician, and I actually have a younger brother who is a physician as well. As a young person growing up, I did not think I had the aptitude or the affinity to, for sure, be a clinician. And I think back on a couple of stories that I've shared before around passing out in biology class when it was time to dissect animals. And so it was apparent to me that I didn't have everything it took to be a clinician. And so I went to college without knowing exactly what it is that I wanted to do, but actually being pretty sure it had nothing to do with healthcare. I ended up getting a degree in philosophy and chose to go to law school, and was not thrilled with law school, as anyone who's had that experience would probably share. It's tough stuff. I toughed it out, passed the bar exam, and practiced law for about 3 years in rural Alabama before looking for opportunities to go back to school and do something else. And so it was actually job dissatisfaction with life as a lawyer that led me to explore healthcare administration. And I reached out to a mentor and a friend of the family who was at the time CEO of Erlanger Health System in Chattanooga, Tennessee, a gentleman named Skip Reeder. And Skip talked to me about healthcare administration. He talked to me about being able to help doctors and nurses and pharmacists and hospitals. And he explained it's healthcare is very heavily regulated. There are lots of contracts and business development. So the legal background that I had wouldn't be wasted, and I might feel differently about what I was doing every day to earn a living and pay back loans. So I did a little bit of research. I mentioned I'm from Birmingham, Alabama, and UAB, the University of Alabama Birmingham, has a wonderful health administration program. I was fortunate enough to get accepted into that, and did a dual master's in health administration and a master's in business administration, a coordinated degree program. While I was in school, I worked part-time as an in-house lawyer at a health system. It was Eastern Health System at the time,
Okay.
acquired by Ascension, and now I think it's all operated by UAB. And the combination of school work in health administration, being able to do some part-time work for a multi-hospital health system, really let me know I was in the right place. I needed to do a residency in healthcare administration, and I went to Dallas, Texas, and did my residency or fellowship with what is now Baylor Scott and White. And For the last 26, 27 years, I've worked in multi-hospital, mostly academic, but some community-based healthcare systems in different parts of the country. And it's everything that I hoped. I have an opportunity to be useful, to be able to support really talented, dedicated clinicians who are trying to care for people today, all over the state of Missouri with a focus on our 25 county service area.
Yeah. Well, tell me how your lead. I mean, that's obviously unique, right? And not every leader in your position has that strong legal background. I mean, where do you feel like it shows up most for you today as an asset?
So when it comes to growth opportunities and partnering opportunities, I think having gone to law school and knowing my way around a contract, it has helped me in understanding how a theoretical discussion with a critical access hospital or a larger healthcare system, how that may look in terms of structuring a written agreement. So I think going to law school probably helped me in terms of growth, business development, and partnering. But these days, I am really fortunate to work with amazing lawyers in the Office of General Counsel for the University of Missouri System, and we work with some talented outside lawyers. So I try to let the professionals do their thing and to stay in my lane.
Right. Delegate to some of the best on your team, right? Well,
Yes.
obviously, with this, this podcast being really centered around rural health, our listeners being other rural health leaders, I think it's not a bad segment to kind of segue into just citing Missouri as among one of the states that's facing, I'd say, some of the most serious rural hospital instability amongst other states, and I'd love to hear from your perspective specifically how you would describe the current state of rural health here in Missouri, and what trends really concern you at the moment.
Yeah, I think if I had to sum it up in one word, I would say fragile. So I think the status of rural healthcare in Missouri and in many parts of the U.S., if not most parts of the U.S., is that it is a really fragile ecosystem. And I do want to distinguish between healthcare generally and rural hospitals more specifically.
Yeah.
But the truth is that the status of rural healthcare is absolutely influenced by the presence or absence of rural hospitals and physicians that work at those hospitals, nurses, pharmacists, therapists, et cetera. So in Missouri, more specifically, we have lost hospitals in Boonville, Fulton, and Mexico in the last few years. As I alluded, when a hospital shuts down or significantly cuts back its services, that affects healthcare more broadly in the community. And it also just affects the community more broadly. So in a lot of towns, the hospital is one of the larger employers.
Yeah.
When a hospital closes, a lot of the clinicians that were providing care are forced to look for opportunities someplace else. In the US in general, there are real shortages of most clinicians, physician shortages, nurse shortages, pharmacy shortages. And so the people that are providing care in rural Missouri and rural parts of the US, they have options, right?
Right.
But it usually involves them having to leave and go to a larger community in order to keep doing what it is that they trained for. So when a rural hospital closes, it has this kind of compounding effect. It weakens the overall community infrastructure. It weakens the economic stability of smaller communities. And it also impacts access to care. And that's one of the reasons that I think it's both uh, ethically and morally important for large healthcare systems, especially public academic health systems like us, to be actively engaged with those communities and to try to look for opportunities where we can work together and preserve access to care.
Yeah. Well, obviously, that happens to a community, and they not only lose all of that, but they tend to lose their identity, right? I mean, or they can as a community. And so when you think of the fragility that's occurring in rural health, I mean, where do you place the weight on the problems, right? I mean, there's a cost problem. Is it a scale problem, a revenue problem? I mean, they all kind of add up, but what do you see from your seat, looking at some of these closures you've just described right in our backyard?
The short answer, Brendan, is yes. It is all of those things. So yeah, there was a movie many years ago, The Perfect Storm, and it talked about all of the things that had to come together to create this massive North Atlantic storm. The analogy there, I think, is probably apropos here. So it isn't just one thing, but you've talked about several of them that I think are really important. Workforce shortages, right? So the national physician and nursing shortages. So for rural communities, then you have to compete for a national and sometimes international market to get talented clinicians to come to your community. In addition, when you are able to get those folks there, having enough volume, enough population to keep busy is another aspect of a workforce pressure. Cost pressures, and whether it's on supplies, drugs, labor expense, all of those things put a little bit more pressure on healthcare systems nationally. And for larger organizations, we experience the same pressures, but our ability to tolerate them and our margin for error is different from smaller hospitals with smaller cash reserves and less resources. The reimbursement environment for sure is really difficult. And in general, Medicare and Medicaid make up a large part of the patient populations for public academic health systems like ours, for critical access and rural hospitals, and reimbursement for Medicare, Medicaid, and Medicare Advantage in general tend to be below the cost of providing care. So there's reimbursement pressures, there's cost pressures, there's recruiting a workforce and then being able to retain them and keep those folks busy and happy. And then there's also just a larger shift nationwide to having more and more care be provided in an outpatient or an ambulatory setting. And if you think about smaller hospitals, their ability to invest in a new outpatient department or a new outpatient service or to put money into an innovative technology, that looks very different. And so the push to ambulatory, just in general, also has a negative impact on smaller rural hospitals.
Right. I mean, the way they look at a rural critical access, hospital looks at risk, and the way MU Health look at risk for those types of investments is obviously vastly different. I mean, can you walk me through how, MU Healthcare responded when hospitals in the places you described, like Boonville and Mexico, when they closed, and what did these closures teach you about acting sooner and the impact that can have prior to community losing its hospital?
Yeah, so MU Healthcare has got, I think, a really good track record and a really good history of being a partner, but not being intrusive in working with distressed communities when there's been a stressor on a hospital or a closure. So in Boonville, we moved to quickly establish first a temporary care solution, and then we were able to transition that to long-term permanent facilities that restored at least some access to essential services. So whether it's primary care services, urgent care services, pharmacy, labs, some imaging, therapy, etc.
Nice. Well, I mean, there's obviously been discussion around, and I should preface, I meant to, this could of course be edited, but Rick, just talking about, the bill that was on the House and the Senate. Are you comfortable kind of talking about that a little bit? Just
Yeah, I'm okay with it.
broad strokes. Yeah. So, Rick, there's been discussion, I think, this year around giving MU Health more flexibility to partner with or acquire rural health care facilities, even where, traditional antitrust concerns might come into play. From your perspective, and given what you've shared about, Boonville, Mexico, how should Missouri balance two real concerns, right? One being the preservation of competition, local control, that discussion, while also making sure rural hospitals have the scale and support they need to survive, right?
Yeah, so the intent behind the enabling legislation was to address one of the things that you mentioned, Brendan, and that is the importance of timing. And the closures in Boonville and Audrain in Mexico were prior to my arrival here. So as I'm working with colleagues who lived through that here in Central Missouri, what was described to me was that there was really very little of any notice. And so when we are looking at trying to move relatively quickly to
Right.
partner or affiliate with a hospital in our 25 county primary service area, having a clear understanding of what the barriers are and being able to have a clear path beyond any regulatory barriers is one of those things that's of critical importance. And so, when we look at um, hospitals that have a dozen days cash on hand, right? And they're trying really, really hard to keep afloat, to keep patients being seen. It doesn't take a lot to take an organization that's on the bubble and create a real crisis. And so, in those moments where we may not have a lot of notice, it would be beneficial to have an environment where there was more regulatory certainty. In other words, we knew that if they wanted to talk to us, that we could do so without antitrust concerns. The legislation, as you're aware, did not pass. That the session that does not, I think, change the importance of us continuing to be vigilant, continuing to try to be a big partner. I think for the foreseeable future, if there are uh, hospitals that are interested in working with us, we just have additional review that
Right.
we need to be prepared for.
How do you typically quantify? Because I think it's valid, right? But how do you quantify the difference between having some sort of blanket immunity versus having to go through the regulatory hurdles? I mean, what? I know every deal, every system could be different, right? But what is that at? I mean, months, year, potentially, right? I mean, it's. I know it's hard to say, but
It could, and then, so there's the time component, there's the lack of clarity, and then there's also money. And right, so this is all hypothetical, but you go back to that facility that had 12 days of cash for that facility to try to go and hire antitrust lawyers and seek regulatory approval. It really puts an added element of financial pressure and timing on what in an ideal world, I think would be a simple question of is there need and value in a relationship of some sort, and whether or not we're able to try to provide sources and resources and we can add value as a healthcare system.
right. Well, let's shift gears, and I mean, obviously, when we talk about thinking of comprehensive specialty care and how it's accessed for rural mid Missourians and really beyond. I mean, how are you bringing specialty care closer to these rural patients, and what's important to highlight there?
Yeah, so we're bringing specialty care, expanding that in Missouri a couple of different ways. So one is we are investing in new facilities and services. We bought some land in Callaway County recently, and there is a project where we're going to expand urgent care and family medicine. That should also include some advanced imaging and lab testing and hopefully down the road access to some subspecialists who would rotate through that facility. So their, mechanism number one is we are investing in new facilities in communities in our primary service area. Another way that's a little bit less high profile is we're trying to improve our processes and workflows to expand access to care. So, for example, I guess it's been about a year or so, we had a real challenge along with some other providers in Central Missouri with being able to provide timely access to gastroenterology services, endoscopies. And our operational leaders, our physicians, our nurses, our administrators really looked at what we could do to expand access to those services by workflow improvements and schedule changes and looking at technology and all of the ways that without necessarily having to build a new building, that we could expand access to care. And there's been some significant success with that. So, mechanism number one is there is investment in new facilities. Mechanism number two, we're trying to work more effectively and more efficiently and use technology wherever possible to expand access to specialty care. And then the third thing I would say just around specialty care is our long-term plan for Keene Street Medical Center here in Columbia is to make that an ambulatory specialty care hub. So there's already a neurology clinic there. We're looking at GI services there longer term, being able to expand those. We've got a non-oncology infusion unit that is there. And we're looking really carefully at how we can centralize access to specialty care and leverage a building that we already own to be able to
Yeah.
provide care to people in our service area.
Well, that's fantastic. I mean, when you think of centralizing specialty care, that really blends well into kind of questions I have around successful rural partnerships, right? I mean, when I think of the care that can be brought from an academic medical center that's critical, right? I mean, when I grew up in Sedalia, Missouri, and having MU close to home was huge for a lot of my friends, a lot of my family members. I mean, I would love to know in what ways give me some examples of what successful partnerships look like. And I know no one is the same.
Yeah. So I think it really begins, a successful partnership begins with a careful examination of what the community needs in terms of healthcare. And the context here is that every community is a little bit different. And there is not a one size fits all approach to MU healthcare working with a community hospital. In other words, we look for gaps. So if you think about up in Moberly and Kirksville, we have a relationship with those facilities where we're able to provide emergency department support or women's health services because that's what those communities needed. In Herman, we've got a relationship around emergency department support as well as inpatient hospitalist coverage. We've had orthopedic coverage arrangements. We've got a trauma coverage arrangement. And this idea that what's right or helpful for one community will necessarily be right or helpful for another community is is not accurate. And so a successful partnership begins with, all right, what resources are in the community? What services offered there? And then what are the gaps? And then we talk about how can MU Healthcare assist with that. The other bit of context that I think is really important in terms of successful partnerships is there are larger academic places and a lot of larger city hospitals are capacity challenged, right? So we have more patient volume than we have beds on any given day. And so as you enter into a partnership with the facility, the a founding premise really has to be, look, we're trying to keep patients local. We're not trying to drag patients to Columbia for unnecessary care. In fact, what we want to do is keep lower acuity patients that are appropriate for a community hospital or a critical access hospital close to home and be able to increase the number of patients that are able to stay in their own community. So if is in a partnership arrangement, it's really important for people to understand motives. Yeah, and in part because MU Healthcare, and I think a lot of large systems are capacity challenged. The goal is not to steal patients, right? The goal is to try to keep care local, provide additional resources and support, and fill in gaps so that people are able to receive the care that they need.
Yeah, I'd be curious. I mean, which specialties in every region's different, right? When we think about rural care, but that you've seen be most necessary to be centralized, and others where it's most necessary and common to be brought closer to patients, where they live.
Yeah, there are some that I think there's a lot of demand and interest in, and actually I alluded to the big two already.
Yeah.
So if you think about the role of emergency departments in hospitals generally, and the importance of emergency medicine providers who are able to see a patient who comes in, assess how ill they are to the extent that that person can be treated right there in the ED and be discharged, great. If that person happens to be sick enough that they need to be admitted, the emergency physician is also able to assess whether or not that patient needs to be admitted at the hospital that they're presenting at, or if that person needs a higher level of care. So, emergency medicine is one of those services or departments that really is important in being able to make decisions about what care can be provided locally and what care needs to go to a higher level facility. Another one would be maternal and fetal medicine. So if you think about some of the OB deserts that exist in the state of Missouri and across the country, having a mom who presents and has some complications at a smaller facility, whether it's on-site access to maternal fetal medicine specialists or telehealth access, being able to assess whether or not mom and baby can be cared for successfully in the rural or smaller facility, or if they need to be transferred. That's another area where we do provide support to hospitals currently, and there's a lot of demand and interest as there's more and more pressure on obstetrical departments in hospitals across the country.
Right. We're seeing that. So you're seeing more successful partnerships or at least discussions happening on that front all the time.
There's a lot of interest.
Yeah. Well, what changed? I mean, talking about partnerships, we've talked about closures, but just successful partnerships, right? I think it's very easy to say. I mean, what changes as it relates to Capital Region Medical Center since joining MU Health? What changes have you seen there? Patient, what's improved for the patient?
Yeah, so there has been a lot of success in our experience together with Capital Region Medical Center. As you're mentioning, one of the areas of success has been patient volumes. So the inpatient census there has almost doubled in the 2 years that CRMC has been a part of MU Healthcare. We're seeing expanded ambulatory volumes. We also have seen a change in the mix of services that we provide there. So we added an ED observation area. We've been able to add critical care support. And those are new services for CRMC or newer services for CRMC, but they directly impact the acuity level of the patient that we're able to care for there. And so there's kind of this dual impact. So one, yes, we've added some new services there, but in doing so, we're now able to care for people that are a little bit sicker, which has also helped us with our census and being able to keep more care local. Improvements in the emergency department and its efficiency. And we have overall, I think, had a really positive experience with Capital Region.
Yeah, no, that's fantastic. Well, and I just love hearing the full picture. I mean, you've added services, improved services, just like when we think of partnerships with other rural and Jeff City's a little bit different than what we think of with critical access, right? But were there services where you said, we're so close to Columbia, maybe it would make sense to consolidate or reduce some of the capacity in this service line or that one, or maybe not so much.
No, it goes back to the element of context that I described to you. So for most of the services that we have in Columbia,
Right.
we're at or beyond capacity. And so being able to provide additional access to care by using existing facilities and providers was one of the win-win elements that a CRMC integration brought to the folks that were in Columbia. So, at this point, we really are focused on being able to expand access to services. When we look at the larger community, we're serving a 25 county area. And one of the things that has contributed to the improvements at CRMC is the types of patients, the catchment area of patients at Capital Region Medical Center has gotten a little bit broader because they're a part of MU Healthcare.
Right.
So when we see patients from the periphery of our primary service area, if they're appropriate and don't need the highest level of cardiac care that you can only get at University Hospital, then we'll transfer them to CRMC. And so the
Yeah.
rather than consolidating or removing services in Jefferson City, we have been trying to maximize capacity so that we're better able to serve people across the region.
Yeah, that's a fantastic perspective. And you've been doing it in other areas as well. I mean, I understand you've launched a new clinic in Holt Summit, right? With an innovative partnership with the MU's, Sinclair School of Nursing. And we think about all the talk around rural transformation. I got to ask, I mean, is this a glimpse of a repeatable version of future rural access models that can be reproduced successfully?
I sincerely hope so. And you're spot on. So May the 5th, we opened up a new primary care clinic in Holt Summit. It's in partnership with the MU Sinclair School of Nursing. And we will have advanced practice providers that will be working with some students. They'll also be working with emergency medicine physicians to help ensure that patients in and around that community are able to get the care that they need. It will offer convenient access to traditional appointments, but there also is the availability of some telehealth services as well. So this is a new model for us, and we are really excited about it and really intrigued for the promise that it may bring in the future.
Yeah. I should ask what led to that expansion. Was there a survey? I mean, tell me a little bit about that process because I'd love to understand entering that market. What led to that? The evaluation that took place, and getting
Yeah,
any color there.
so the combining of several different things. So one, we had a really passionate advocate in Dean Lori Popejoy over at the Sinclair School of Nursing, who's been really interested about the possibility of developing a primary care clinic using advanced practice providers in this way. So one, we had a champion in Dean Popejoy. I think two, with the integration of Capital Region Medical Center, the way we have looked at those areas right around Jefferson City has been a little bit more focused and a little bit different. And so we've been really curious and interested in how we can better support Holt Summit as a community. And then, three, we do look at our obligations across Central Missouri as this is our primary service area. We have a responsibility to try to provide access to both primary care and specialty care. And an innovative way to add access in this way in Holt Summit was something that just checked a lot of boxes for us and we felt was important to try to do.
Yeah. Well, I'd be curious what, just in general, I mean, whole stuff we've talked about, but what opportunities you see, on the horizon for improving rural health care over the next several years, given all the challenges, given all the headwinds that we have. I mean, would you be able to rank kind of what you feel the biggest opportunities are amongst, call it workforce, technology? We've talked about payment reform, system collaboration. What comes to mind as some of the, I don't want to call them lowest hanging fruits, but things that might be most attainable, realistic.
Yeah, so I am intrigued, but also a little cautious about the ability of technology to really revamp and reinvigorate rural healthcare delivery in rural hospitals. So the promise of solutions to some of the current workforce challenges, that is really intriguing and I think cause for hope and optimism. I also am old enough that I've seen supposed technological panaceas for a lot of either health system or ills of other industries. And so I'm still probably on the cautious side about how much technology will dramatically change things. But technology for sure is one of those things that I'm cautiously optimistic about. I think investments in workforce training. That's one that I would rate pretty high on the list of things that can impact healthcare delivery more broadly, but also rural healthcare delivery. And you go back to the question you asked me about what the contributing factors are. And when I was sharing the perfect storm analogy, I mentioned workforce. So workforce investments, workforce training, just as that can be a destabilizing influence on hospitals and healthcare systems in rural communities, the flip side of that is investments in those areas and improvements can also be a stabilizing influence. And so I think workforce investment would be one that I'm pretty optimistic about. Another one that I also think is going to be really important is payment reform or payment changes of some sort. And I do think that HR 1 long term is going to make things a little bit more difficult for all hospitals, but especially rural and critical access hospitals. Senator Hawley and a few folks, I think, have really taken the issue to heart and have proposed things like the Rural Health Transformation Fund. As we all are learning a little bit more about how RHT is being rolled out in different states, I think there is some appropriate concern about the ability of the Rural Health Transformation Funds to really serve as a lifeline for smaller hospitals in the way that I think many people had hoped.
Yeah. Well, and I think there's a lot of education that has to just take place there, right? The misconception around what it's for and what it's being used for. I mean, in so many ways, you think about how Missouri's taking a leadership stance with the Torch pilot program, and now to the Torch Cares program rolling out through the Rural Transformation Office. I mean, where do you feel like Missouri as a whole is a leader right now, rather than trying to play catch up as it relates to rural health transformation? You talk about technology, maybe siloing out some areas where you feel like that's really making an impact from your seat where you can see it.
Yeah, one of my causes for optimism is, in fact, our state hospital association, the Missouri Hospital Association, is quite frankly stellar. So, as an old dude who's been around the block and been in some different states, I can tell you, based on my experience for sure, we have incredibly talented leaders at the Missouri Hospital Association. John Doolittle, Jane Drummond, and others are doing a really good job of working with rural hospital leaders and have been very, very active and involved in everything from working with the Missouri Department of Health and Social Services and on our application to now that we're at a place where the RHT funds are being administered, being a good partner and advocating on the behalf of members at that stage. So I do think the Missouri Hospital Association has been incredible, and we need them to be incredible at a time that's pretty challenging for hospitals across the state.
Yeah. Well, as we think about in finality, kind of one actionable item we can take away from this conversation. I mean, what's one mindset shift you believe rural healthcare leadership just needs right now? And what's one action that can be taken this month?
Yeah, I would, ask for consideration of any of the policy issues that can be shaped at the state or federal level that will impact hospitals directly. The pace of change has been quite a lot in terms of policy changes that affect healthcare systems and hospitals. And so, for our legislative leaders in Missouri and also in Washington, the request would be please be on the lookout for things that can support hospitals back home in your districts, and please interact with those hospital leaders. One of the things that I'm also really optimistic about for Missouri is we have got some talented, passionate leaders of hospitals throughout the state. So Bill Hellebush over at Herman Hospital, Lori Whiteman over at Bothwell, Craig Thompson up at Golden Valley, Tina Gillespie at Harrison County Community Hospital, and then Tylee Mills up at Pike County all come to mind pretty easily. The strength of leadership, the interest inside their respective communities is cause for optimism. We just have to navigate the barriers that we're all experiencing as an industry.
Yeah. Well, I mean, there's been visible barriers, right, with payer issues, right? We talked about that, and all of the systems you just mentioned, I think, are all for the most part involved in trying to do more collaboration with a company that's coming in to help develop a sin, right? To hopefully have more leverage in that regard. And so I'd be curious your thoughts on that, right? I mean, you're no stranger to those battles and having those discussions. I mean, do you have optimism around what's going on there and that it will have a meaningful impact quickly enough?
So I'm less familiar with the project, the Ascend project that
Yeah,
you're referring to. I am a big fan of the MHA's Torch program and the idea that Torch will really become the model that we're using with rural health transformation funds. I'm not able to comment really on Ascend. What I can tell you is that those organizations, the leaders of those organizations, the Missouri Hospital Association, those are all folks that are invested in trying to keep rural hospitals strong and the center of care in communities throughout Missouri.
absolutely. Well, Rick, this has been a fantastic perspective. I've really enjoyed having you on the program. Any parting thoughts for our audience? Anything you'd love to share before we wrap it up?
No, Brendan, again, I am flattered and honored to be able to spend some time talking to you today. And I want to thank you for the opportunity on behalf of MU Healthcare, the School of Medicine, and all of the team members that I work with across our organization.
Well, it's been fantastic hearing from you and appreciate you coming on board.